siapa yang lead the exam. Because during the professional exam, dia ada dua examiner. Most of the time dia akan combine lah. One is the surgical base, punya surgical base punya specialty. Surgical base ni boleh boleh jadi ortho, surgery ataupun ONG. The other one is a medical base lah. Okay. Jadi most of the time kita combine kan, is sama ada surgical base plus medical base lah. So you see who lead the exam. Siapa lead the exam? So tak kenal saya kan. Kalau saya lead the exam, so maksudnya the patient is of course lah surgical patient. So kalau macam doktor Dr. Naim ke apa ke yang medical kan lead the exam ataupun Prof Hao ke apa ke. So confirm lah is a medical patient. Okay, so is roughly can help you lah during the professional exam. Because during the professional exam is you have three factors. First is yourself. Either how prepared are you during the exam for the exam. Second, examiner. Kalau the examiner can be you can get a benign or malignant examiner. Third, the patient. So all these three factors, kalau okay, then your exam will be okay. So it's a difficult to say. Sometimes you okay, but the examiner okay, but the patient not okay. Sometimes the examiner also the patient okay, but you are not okay. So difficult to say. All these three factors okay, then you will pass your exam, inshallah. Okay. So we start with the colorectal carcinoma. Okay, so colorectal carcinoma is one of the common case you will see during end block exam, during professional exam, and also once you become a houseman or once you become a doctor. Okay, so colorectal carcinoma is a second most common cancer in Malaysia. Okay, so the three most common cancer. So kalau in the surgery is colorectal and also the breast cancer lah, and also another one is a lung cancer. So but the lung cancer be managed by the respiratory team. Okay, so 80% of the patient is more than 60 years old. Okay, so if the patient come with the bowel symptom, and the age is more than 60 years old, you must put colorectal carcinoma is your provisional diagnosis until proven otherwise. Colorectal carcinoma is your provisional diagnosis. This from your as you can see from this slide, the patient can have outer bowel habit. The most common cause can be either diarrhea or constipation, parectal bleed, abdominal pain, weight loss, anemia, and also intestinal obstruction. Okay, this is okay, but for the left side, okay, but history that can help you either to determine either this is a right side or this is the left side. So if right side, the patient, in the left side, the patient will have left side outer bowel habit. On the right side, so patient will have the left side left side patient will have outer bowel habit. Right side patient will have anemic symptoms and also abdominal mass most of the time. Okay, kalau rectum dia akan rectum the symptoms same like a left side, tapi dia ada but the patient will have tenesmus also. Okay, there's one case masa the last professional exam, patient come with the anemic symptom. Dia tak ada bowel symptom, anemic symptoms. And in the same time masa examine tu dia ada abdominal mass. Okay, so some student able to get the history, some student unable to get the history. Lepas tu plus is a difficult patient some more. Difficult patient some more. Okay, so ada yang some student get able to get through lah. Some student unable to get through. Sekejap slide ni dia hang pula dia. Sekejap, saya punya slide dia tak bergerak lah.
Alright, stay.
Dia kau ni. Yalah, tak apalah, ni sementara tunggu ni. Okay, so if the patient come with the, ni suara saya dengar?
Dengar, Mister.
Dengar, Mister.
Okay, so sebab ni nak tunggu slide open ni saya pun tak tahulah. Dia sometimes dia memang macam ni. Time apa, time yang kita nak benda ni jadi, benda tak jadi pula. Okay, so if the patient come with the kita start from the history. Okay, so for the colorectal carcinoma, so we must differentiate either is a right-sided colon cancer, left-sided colon cancer, and also either is a rectal carcinoma. Okay, so for the right side colon cancer, the chief complaint is is an anemic symptom. Rarely patient come with the bowel symptoms. Sometimes patient come with the abdominal mass. Okay, so you ask the patient, this is the trick. Okay, this is sometimes yang the student tertangkap. Reason because patient come with the anemic symptoms. So anemic symptom which is generalized body weakness, lethargy, shortness of breath, palpitation, difficulty in breathing. Okay, so if the patient come like that, usually what is in the student's mind? Apa yang diorang fikir? Is it surgical case ke medical case? Salah seorang. Oh, akan fikir medical case. Okay. So this is how kalau macam apa dah cerita Sherlock Holmes kan? Sherlock Holmes is a detective. So this is how you want to manipulate all the information And also plus tengok depan siapa yang lead the exam. Kalau macam saya ke lead the exam, Prof Azmi ke, ataupun Mr. Fasad lagi lead ke, takkanlah apa heart disease ke COAD, kita orang nak tanya apa. So tengok who lead the exam. Okay, that somehow is a trick lah, I can help you. Okay, second, okay, ask regarding the, okay, ask regarding abdominal mass. Okay, some patient can feel there's a mass. Okay, some patient cannot feel. Okay, but once the patient seek treatment from the healthcare center, so say okay, I come for apa for the medical checkup ke apa ke, and then the doctor said there's a mass inside my abdomen. Okay, so once you get that history, okay, so finish everything regarding the anemic symptoms, and then the abdominal mass, painful ke, pain ke apa increasing size ke apa ke. Okay, then don't forget to ask regarding the metastatic symptom. So colorectal cancer usually the mass to the lung. Okay, as to the lung and also to the liver. So if patient mass to the liver, so the patient will complain of hypochondrial pain, then Euler's discussion of sclera, T color urine. Okay, but there is no pale color stool, there is no pruritus. Okay, because this is not ulcerative jaundice. So patient complain Euler's discussion of sclera, skin, also T color urine. Okay. Then if the left side easier, patient will have typical presentation is constipation, and then a patient will have diarrhea. Okay, so how the patient will describe is diarrhea alternating with constipation. Okay, because the theory is the right side of the colon cancer, it is a fungating tumor. It's a fungating tumor, and patient will have kita panggil occult bleed. So what is occult bleed? Occult bleeds mean that the patient have bleeding, but the patient have a bleeding, but clinically not visible. Okay, but on the left side, the tumor growth is a annular growth. Maksudnya dia tumbuh secara circumferential, and then it will cause the lumen become smaller and smaller and smaller. Then that's explain why the patient have constipation. Mean that because the diameter of the lumen becomes small, and then the feces will be difficult to go through. Okay, then what will cause the patient will have a constipation. So how can we explain diarrhea? Okay, because once the patient have once the feces difficult to get through, and then the patient will have impacted stool. Okay, then because of the activity of the colon bacteria, okay, then also high pressure from the proximal bowel. Okay, then by time the feces from solid will liquefy, and then because of the high pressure, so the patient will have diarrhea. The patient will explain this is a spurious diarrhea. Okay. Okay, and also the patient will have constipation also because the diameter of the left side, especially the sigmoid colon, is smaller compared to the right side. Okay, on the rectal CA, left side colon CA symptoms plus tenesmus. Okay. And the last history, don't forget to ask the patient regarding the risk factor. Okay, risk factor of colorectal cancer. Okay, is a family history of colorectal cancer. Okay, other risk factor difficult for us to ask the patient. Okay, because high meat intake, high processed food intake, low fiber diet tu susah sikit Bukan susah apa, because everyone pun makan McDonald juga. Everyone pun makan nugget, makan KFC juga. Okay. Then what you can find during physical examination? Okay, physical examination. Okay, if the patient in colorectal cancer, okay, so the patient looks thin or sick. So sometimes the patient complain of a pain. Complain of sometimes when you examine the patient look pale. Okay, the patient look pale. Okay, and then if the patient have liver metastasis, you can see there's yellowish discoloration of the sclera. Okay. Yellowish discoloration of the sclera. And then for colorectal cancer, ada tak palpable Virchow's lymph node? Virchow's node, palpable ataupun tak? Colorectal cancer, palpable tak Virchow's node? Prof. Singstein positif ataupun tak? Tak, okay. Because the palpable Virchow's node, if the cancer originate from the hepatobiliary or from the upper GI, so kalau colorectal cancer, dia tak palpable. Dia tak palpable. Yo, kesian lah korang ni. Bukan barulah saya punya slide ni dia nak function. Ni nampak saya punya slide ni?
Nampak, Mister.
Nampak.
Nampak.
Oh yo. So, berapa lama saya present, tak, dia memang kadang-kadang memang macam ni. Time nak exam masa tu lah apa stetoskop tak function lah benda-benda last minute ni. Okay, so during per abdomen, okay, then you will if the right side, okay, if the right side, okay, most of the time you can feel abdominal mass. Left side boleh palpable tak abdominal mass? Left side pun boleh palpable abdominal mass juga. Okay, left side pun boleh palpable abdominal mass juga. So if palpable abdominal mass, most likely is already T3. Okay, if the mass is fixed, so it's already T4. And don't forget to check for hepatomegaly, and don't forget to do rectal examination. So for lung examination, then you can see presence of the if the patient have lung mets, so there will be presence of pleural effusion. Okay, so investigation, okay, investigation apa yang common, FBC, RP, LFT, correlation profile tu standard lah yang tu kita we no need to discuss. Okay, the diagnosis for colorectal cancer is the gold standard is colonoscopy. Okay, so why we want to do colonoscopy? So ada 6 reason. Okay, that's why if you do colonoscopy, you already find the tumor. Okay, do we still need to complete the scope anticecum or not? Yes. Okay, because first the reason for direct visualization of colorectal mucosa, that's from the colonoscopy. Second, we can know the location of the tumor. Okay, from the scope we can see. We can know how centimeter from the end verge, and then we can roughly estimate the location of the tumor. Okay, then tissue biopsy. We can take a tissue biopsy for HPE, and then another reason why we have to complete the scope until the cecum, because we want to look for synchronous tumor. So synchronous tumor. I usually tell my student, you remember one figure, you remember another figure. So synchronous tumor ni is about 3 to 4%. Ni saya tulis sini 3.5% kan. Dia yang point-point ni susah nak ingat. Masa exam confirm tak ingat punya. Is 3 to 4% for you to look for synchronous tumor. Means patient have a tumor in one side, and then you can find another tumor in the other side. Contoh tumor in the rectum, but the patient also have tumor in the cecum. Okay, then you want to look for synchronous polyp. Means patient have tumor In the same time, patient have polyp also. So the exact figures about 20% lah. Tapi saya cakap you remember one figures, you remember another figures. So you just add zero je. So kalau polyp, kalau synchronous tumor 3 to 4%, synchronous polyp is about 30 to 40%. And also the risk of a perforation of bleedings not high lah, 0.3 to about 0.2 to 0.3%. Okay, so kita ingat satu, kita ingat satu, kita ingat tiga. Kita ingat satu apa? Kita ingat 30%. So synchronous tumor 30%, kan? Synchronous polyp, synchronous tumor 3%. Okay. Synchronous polyp tambah lagi satu, tambah kosong, so 30%. So risk of perforation and bleeding 0.3. So ingat satu nombor, you ingat all the three numbers. Senang kan? Okay, senang.
Boleh.
Okay, jadi CT, okay, if fail colonoscopy, fail procedure of colonoscopy can be because of multiple factors. Because a patient have a previous history of surgery, then the patient have bowel adhesion, or difficult, they are difficult during colonoscopy because of acute angulation. Okay, so then we have to do CT colonography ataupun kita panggil visual colonography. So visual colonography, the sensitivity is quite good, 90%, especially if the patient have tumor or the patient have polyp more than 1 centimeter. Okay, so for CEA, okay, by right, CEA is used for monitoring and follow up. Okay, we not use CEA for diagnosis because the CEA, although is sensitive, but it's not specific. Okay, tengok the overall sensitivity of detection of primary colorectal cancer is 40%. So maksudnya okay, dia because a lot of because early stage of colorectal cancer, stage 1, especially stage 1 lah, the CA usually not raised. Okay, but the patient have a cancer and also it's not specific also. The patient with inflammatory bowel disease or colitis, ischemic colitis ke apa ke, the CA also will raise. Okay, so we use CA for monitoring and follow up, and also CA also if can reflect in the prognosis of the patient. Okay, because if the patient have a high CA, okay, most likely the patient already have distant metastasis. Okay, jadi CA sepatutnya kita ambil bila? Before HP balik ke after HP dah balik? Sepatutnya kita ambil after HP dah balik.
After dah balik.
Sepatutnya, ya. Tapi kalau tengok dekat wall tu selalu kita belasah kan. Yalah, sebab CA ni satu keputusannya balik cepat. And then HPE selalu keputusan balik lambat. So selalu kita take je. Okay, okay, so management. Okay, management of the colorectal carcinoma. Okay, depends. Okay, either the patient have colorectal or have a colon cancer or rectal cancer. So rectal also depends the location of the tumor. Ada is upper rectum ataupun mid and low rectum. Okay. Jadi for colon and also rectal carcinoma, colon means right side, left side, rectum upper, mid or low. Okay, all the patient need for staging. Okay, the staging we use CT TAP, CT thorax, abdomen and pelvis. Okay, because first we want because first for the to look for distance metastasis, which is the M staging. Second, you can see presence of the local complication. Okay, example, if the patient come with the perforation, perforation, sometimes the patient have seal perforation. Okay, or the patient have intestinal obstruction. New case, intestinal obstruction, we're not sure what is the diagnosis. So we can do a colonoscopy. Okay, so can you do colonoscopy if the patient come with the internal obstruction? It's cannot, because it's a contraindication. Can you do scope if the patient come with the perforation, you suspect patient perforation? Cannot also, because you can worsen the perforation. Okay, but for mid and low rectal cancer, you must add one staging. One imaging investigation, which is the MRI pelvis. So for the rectum, you can divide the rectum into upper, mid, or low rectum. Okay. Our rectum berapa panjang? Berapa panjang?
15 to 15 centimeter.
15. Depends how, because the rectal length is between 12 to 15. So every part is either 4 to 5 centimeter. But actually, we can know exactly intraoperatively, kita boleh tahu. We see at the we see location of the sacral promontory and also the peritoneal reflection. Okay, tapi from the imaging ni difficult sikit lah. Tapi usually kita ambil between 12 to 15. So every part is either 4 to 5 or 4 or 5 centimeter. So kalau one part 4, 4 macam 12 lah. So kalau 5 macam 15. Okay, but the student usually they make a mistake. Bukan the student, kadang-kadang doktor pun make a mistake juga. Okay, because if they do the per rectal examination, our finger, let's say our finger, macam jari saya ni boleh sampai 7 cm, jari saya panjang. Okay, tapi mostly people people jari dalam 6 cm lah. Okay, let's say if you able to palpate the tumor, 6 cm from end the verge. Okay, so where's the location of the tumor? Upper, mid, or lower?
Mid
Lower.
atau lower?
Jawapannya low. Why? Because we have to minus 4. Our anal canal berapa cm?
Oh, okay.
4 cm.
We have to 4 centimeter. So actually, so 6 minus 4, actually 2. 2 is a low rectal. The problem is bukan je setakat student, doktor pun sama. Kadang-kadang diorang terlupa nak tolak 4 because our anal canal is a 4 cm. Okay. So if the tumor, the location, what is the exact method for you to use to know the location of the rectal tumor? The exact method, the most accurate, yang paling accurate sekali, kita guna apa? Kalau masuk dalam exam MCQ lah, kita guna apa? The most accurate.
We use sigmoidoscopy.
Tak. Jawapannya ialah kita guna finger. Finger the most accurate. Tapi finger ni kita boleh tahu apa low rectal tumor ataupun tak lah. Okay. That's the most accurate. Okay. Tapi if you cannot use our finger, the most accurate we use rigid sigmoidoscopy. Rigid sigmoidoscopy. That's the most accurate. Okay, tapi usually kita tak use we use our Coinbase sigmoidoscopy or colonoscopy je. Okay, so why mid or low colorectal cancer, we have to use MRI pelvis. Okay, because we want to know the T and N staging. Okay, why you have to know the T dengan N staging? Okay, because there's a role of neoadjuvant therapy. Neoadjuvant therapy is a therapy before surgery. Okay. The therapy because before surgery. So how? Okay, if the patient have at least T3 or T4 ataupun positive N, okay, T3 or T4 ataupun positive N, maksudnya N1 lah, at least N1. So then the patient have to go for neoadjuvant therapy. Means that can be chemo, radio, or chemo plus radio before surgery. Okay, because neoadjuvant therapy first is a reduced risk of local recurrence. Dia reduce risiko cancer tu datang balik, local recurrence. Okay, second, it is a sphincter preserving procedure. Maksudnya by we do neoadjuvant therapy, we can preserve the sphincter. Maksudnya kalau dulu-dulu, kalau the tumor is so low, if once we do the surgery, kita tak boleh apply our stapler di fecal sebab tumor tu terlalu besar. So we have to do APR, abdominal perineal resection. So maksudnya patient, daripada kita buat low anterior resection, kita terpaksa buat APR. So patient will have permanent stoma. But now we able to downstage the tumor, so we can preserve the sphincter. Kita boleh apply kita punya stapler. Okay. Third ni lah, to downstage the tumor lah. Once we downstage the tumor, our surgery will be easier. Lepas tu we can apply our stapler. There will be less risk of complication. So we can downstage the tumor. Okay, there's another option actually. We can do endorectal ultrasound. Okay, tapi we don't do. Okay, because the problem is the tumor is a stenosing tumor. Okay, and also if we want to look the response of neoadjuvant CCRT, is difficult through the endorectal ultrasound. Okay, what is the role of a PET scan? So PET scan we only do if uncertain ataupun equivocal. Is a uncertain ataupun equivocal finding. Okay, contoh, if the patient have a colorectal cancer ke, so there's a small lesion at the liver, small lesion. So from the CT scan pun our radiologist unable to tell the lesion, is it cyst ke ataupun metastasis. So we will do PET scan. So because a PET scan, it will uptake, and then it will enhance during the imaging. So if it is a metastasis, it will enhance. If cyst, then it will not enhance. Okay, we don't do PET scan for every patient. We only do if in uncertain or equivocal finding. Okay, so the surgery, okay, ni senang. Ni senang, bukan senang apa, tak payah pening kepala. Okay, for right side colon cancer, okay, just cakap je. The surgery is right hemicolectomy. Okay, jangan cakap limited right hemi lah, right hemi, extended right hemi, tak payah pening kepala. Cakap right hemi je. Okay, untuk left side, descending colon, colon cakap je, is a left hemicolectomy. Okay, lepas tu kalau rectum, okay, rectal CA apa ke mid ke low ke, just cakap anterior resection. Okay, tak payah cakap ni nama ni panjang ni. Lepas tu mid pun upper rectum pun boleh buat ni, anterior resection plus partial TME, ataupun kita boleh buat wide macerator excision. Tak payah pening kepala, rectal CA je anterior resection, takkan salah. Kalau salah tuntut dekat saya masa exam. Janganlah. Takkan salah lah, because tak macam TME ni, yelah, is a too high level untuk kita punya master student. Okay, then then we go next is a role of neoadjuvant CCRT. So neoadjuvant ni ialah we give either radiotherapy or chemotherapy before surgery. Okay, so this is the indication. So for patient in mid or low rectal cancer, lepas tu T3, T4 ataupun positive nodes, and then actually there is a 3 method how you want to give neoadjuvant. Okay, tak payah tahulah. Dia ada long course, lepas tu dia ada long course CCRT, lepas tu dia ada short course RT, lepas tu dia ada TNT. TNT ni the total neoadjuvant therapy. Okay, kalau nak tahu, tak tahu pun tak apa. Kalau tahu nama je, tak payah tahu the detail. The detail ni apa? Dah kita punya master student punya level. Okay, so indication for adjuvant therapy means that after the surgery, we proceed with radiotherapy. So kalau stage 3 cancer, ataupun high risk stage 2 cancer, which is obstruction, perforation, polydifferentiated lymphovascular invasion, ataupun when the surgery the lymph node less than 12. Yang ni pun tahu tak tahu pun tak apa. Selalunya kita tak tanyalah. So because the technology keep on evolving, semakin lama our surgical technique evolving, become better, then our neoadjuvant and our adjuvant therapy also become better and better. During my time ni macam tua lah pula. Masa saya student dulu, if the patient have liver mets ke, lung mets ke, that's it lah. It's a palliative lah. But now, if the patient have liver or lung metastasis, we able to treat patient curatively. Maksud kita boleh merawat pesakit dengan tujuan untuk menyembuh. Bukan sebagai palliative tapi dengan tujuan menyembuh. But there is a criteria yang nak kena fulfill. So if we able to leave behind at least 25% normal liver. Tapi yang 25 ada 55 ni selalu orang lupa. So saya cakap selalu 30%. If you able to leave behind at least 30% of normal liver, then you can resect all the distant metastasis to the liver. For lung there is no percent. Dia cakap as long as the remaining lung able to function properly, for the patient have good quality of life, so we can leave behind. So usually when we make this decision, selalunya bila kita buat decision ni? Siapa yang decide ni? Adakah colorectal surgeon yang decide ataupun siapa yang decide?
Multidisciplinary team.
Yes, selalunya if the patient have distant metastasis, so we will organize one we call multidisciplinary team meeting ataupun MDT meeting. So we will call macam liver mets kan. So we will call our hepatobiliary team here, which is Prof Mat Saleh, Prof Jun, Prof Nasir, they represent our hepatology team. But the problem our pulmonary, kita punya cardiothoracic surgeon dah quit pergi private. Dah quit pergi private lah. Yalah dekat private kalau apa dia orang offer, kita tak boleh ni, jual A tak boleh nak lawan balik offer. So dia orang dah pergi kita dulu ada kita ada seorang dulu cardiothoracic surgeon, tapi dia dah quit dah. Okay, so now we have to call our cardiothoracic surgeon from a HTE, and then attend by our oncology team, and also our and also colorectal team lah. So we will see and decide. Okay, so kalau patient ada liver mets, lung mets, so kalau kita Prof Jun cakap okay, this liver met I think I can resect, I can leave behind 30%. Okay, lepas tu our cardiothoracic team cakap okay, I can resect the lung mets, and then I can leave behind for the patient to go a good quality of life. Okay, so we can treat the patient as a curative, not palliative. Okay, so the follow-up for the patient. So we follow up for the patient for 5 years, 3 to 6 months. We will follow up. We will see the patient. We will follow up the patient from the history. From the patient complaint, physical examination, and then we will take CA. So the CA will be once every 3 to 6 months. Okay, and then for surveillance colonoscopy. Okay, so year 1. Okay, year 1 ni maksudnya after surgery. Satu year 1, satu lagi year 3 to 5. So masa year 3 to 5 after surgery. So maksudnya scope ada 2 kali. So 1 year after surgery, another one is 3 to 5 years after the surgery. And then CT scan every year for 3 years. Kita buat setiap tahun sampai tahun ketiga. Okay. After finish 5 years, if CA tak raise, patient clinically semua okay, CT scan there's no metastasis, kita buat colonoscopy, there's no recurrence. Okay, means that the patient heal. Maksudnya patient dah sembuh dah daripada rectal CA, daripada colon or rectal CA, dan kita boleh discharge the patient from our clinic. Okay, that's all. Thank you. So anything want to ask? Apa-apa nak tanya soalan?
Kita nak tanya, kan ada TNM staging tu. Do we need to remember in detail every stage tu?
Every TNM.
Yes.
Okay, if you able to remember good, kalau tak remember pun tak apa. Okay, the reason sebab masa exam selalunya tak sampai pun, apa yang detail-detail ni selalunya tak sampai. Kita we ask the patient, we ask the student history, physical examination, and then investigation, and then go straight to the investigation, also management lah. Okay, because masa exam dia bukannya macam colorectal surgeon akan dapat akan lead the colorectal case. Dia tak semestinya macam tu. Okay, dia as long as a surgical case, so kita boleh berjalan dah. Dan macam Mr. Faizal ke vascular surgeon, macam Mr. Azim ke plastic surgeon, dia orang pun tak ingat T1, T2, T3. Yang ingat tu macam Prof Nasir tu ingatlah. Prof Nasir pula, Prof Azmi ingat, Mr. Faisal ingat, macam saya ingat lah. Tapi most of the time kita tak tanya. Kita tanya the clinical. Yang clinical tu more important. Okay, next.
Doktor nak tanya, kenapa neoadjuvant therapy tu kita buat untuk mid and also low rectal CA je? Kenapa bukan upper?
Oh, because the mid and low rectal CA is a below peritoneal reflection. Okay, because upper rectal CA dia above peritoneal reflection. Okay, above if the tumor above the peritoneal reflection, so the rectal CA we manage same like colon cancer. Because mid dengan low, dia below peritoneal reflection, so there's a risk of local recurrence at the pelvic region. Kita panggil from the HP kita boleh tengok, kita panggil CRM. Kita panggil CRM ni stand for cranioradial margin. So which is how far the tumor from the mesorectal fascia. So because the tumor dia akan grow from the mucosa and then dia akan grow outwards. Okay, dia akan grow outwards. Okay, so if we able to give neoadjuvant CCRT, so dia akan downstage the tumor. So maksudnya initially T3, T4, after neoadjuvant CCRT mungkin dia become T1, T2 ke, ataupun ada some tumor yang very good response. Buat neoadjuvant CCRT je disappear terus.
Okay, thank you, Mister.
If you are so there okay. So faham
Faham.
Faham kan? Okay, so okay. Tak apa, ni soalan ni susah sikit, tapi kita selalu tanya master student lah. Okay, if after neoadjuvant CCRT the tumor disappear, will you proceed dengan surgery ataupun tak? Kan neoadjuvant kan? So neoadjuvant lepas tu is kita panggil complete response. Okay, because neoadjuvant dia ada 3 outcome. Pertama complete response, second partial response, 3 no response. Okay, so will you proceed dengan surgery ataupun tak? Tak, ni tak masuk exam, masuk master exam je. Saya nak tengok you guys punya thinking.
Repeat colonoscopy.
Colonoscopy disappear. MRI, because after neoadjuvant kita akan do another MRI sebab kita nak assess kan. Dia complete response ke, partial response ke, non response ke. Okay. So will you proceed dengan surgery ataupun tak? Buat CT scan hilang, buat scope dah tak ada dah.
And for CA doktor?
CA normal.
Tak payahlah
Before
tu.
surgery, okay, jawapannya ialah kita still proceed dengan surgery. Biopsi, kau nak biopsi apa? Tumor tu dah hilang. Jawapannya kita still proceed dengan surgery. Okay. Because complete response dia ada 2. Satu is imaging. Ni tak payah tulis. Tak masuk exam, masuk master exam je. Kecuali kalau korang nak buat master lah. Okay, because complete response ada 2. Satu is a radiological response, satu is a pathological response. So pathological response ni kita tak tahu. Daripada imaging complete response, tapi kita panggil is a radiological kita panggil is a radiological assessment. Okay. Daripada radiological assessment dia complete. Tapi pathologically kita tak tahu. Kita hanya tahu after kita buat surgery. Okay, so berapa persen sebenarnya? 100% kan? Okay, katakanlah 100% yang imaging, 100% imaging, patient have complete pathological response. Tapi bila kita buat surgery, berapa pathologically berapa persen yang memang betul-betul complete pathological response? Teka.
About 30%.
About, jawapannya rendah sikit, 20%. 12-20%. So maksudnya 80% tu still ada CA, tapi imaging kita tak nampak. So that's why kita still proceed dengan surgery. Tak apa, ni soalan ni tak masuk exam, masuk master exam. Okay, next question.
Mister, I would like to ask, how many centimeter above from the anal verge when we can consider anal sphincter sparing surgery?
Okay, so because kita kena ada, kita panggil oncological, kita panggil oncological resection for kalau tapi this one dah too detail lah. Bukan saya boleh cerita, kita boleh buat intersphincteric mucosa resection nanti komponen. Nak tahu ke tak nak?
Kalau macam tu tak apa.
Betul, bukan? Nak saya cerita boleh je, tapi isteri pun bukan kabut lagi kan. Nanti tunggu master tuntut dengan saya. Mr. Yusof, dulu masa saya year 5 saya ada tanya ni, saya nak tuntut kamu soalan ni. Okay. Okay, lagi soalan.
Mister.
Yes. Okay.
You can go ahead, Hassan. All right, so I just want to ask with regards to the PR. On PR examination, does it differ if we actually describe, is it circumferential or circumferential basically lesion? Will that indicate any kind of pathology? Is it anterior or posterior? Is it mid or lower rectal?
Oh no. Okay, because we will take the most lowest palpable tumor. Okay, either it is anterior, you can palpate anteriorly ke or posteriorly to the rectum, no difference. Okay, except if your finger unable to pass through. When you do per rectal examination, okay, the tumor your finger unable to pass through. It means that the tumor is the rectal tumor is will have obstruction in the future. We call it a pending obstruction. Okay, so if the patient have a pending obstruction, so we have to do diversion. We have to do diversion, either sigmoid colostomy or transverse colostomy, and then we have to proceed with the neoadjuvant CRT for the neoadjuvant therapy. Okay, because let's say some people said finger unable to pass through but patient still able to BO. We just proceed je lah with the neoadjuvant therapy, because by neoadjuvant therapy the tumor will shrink. Betul kan? Okay, but the outcome has 3 outcomes. First, complete response. Second, partial response. Third, no response. So which patient will have complete, partial, no response? We don't know. Kita tak tahu. So we have to divert the patient and then send the patient for neoadjuvant therapy. Okay, I hope I answered the question.
Yes, thank you so much.
Okay, any other question?
Mister, for neoadjuvant therapy, we will consider it in T3, T4, or if the nodes are positive, right? So
yes.
we do not consider metastasis at all, or is it that there shouldn't be any metastasis?
Okay, again.
So about metastasis,
yes.
so we do not consider metastasis or there shouldn't be any metastasis.
Okay, so like in this case, because we have to differentiate our management. Okay, first is the management of the tumor. Okay, second, the management of the distance metastasis. Okay. And then we have to see what the aim of our treatment. Either our treatment is a curative, our treatment is a palliative. Okay. So if our treatment is a curative, okay. Curative, okay, means the patient, okay, let's say the patient have a liver cancer. Okay, so we can do liver resection, okay, plus anterior resection, the resection of the rectum. Okay, because you must know, neoadjuvant therapy is not for distant metastasis. Is to prevent local recurrence. Okay, so if our aim is for curative, we will do neoadjuvant CCRT and then proceed with surgery, anterior resection plus liver resection lah. Okay, if our aim is for palliative, okay, palliative, maksudnya dah palliative, liver unresectable, lung unresectable, so kita nak buat neoadjuvant pun buat apa? Why you want to do apa? Why you want to prevent local recurrence? Padahal patient dah mets everywhere dah. Okay.
Alright, thank you, Mr.
Okay. Okay, any other question? Ya, tadi saya
ada soalan dalam chat box.
Itulah, buka jap. Apa benda lah slow sangat ni. Korang tanya je lah ni chat box nak buka ni pun aduh. Sekejap, message can only be seen by people.
Sebab sister tu dia tak ada mic, tapi saya bacakan soalan dia.
Okay. Kita berapa ni? Alternating bowel habit tu macam mana with duration? Once ada constipation, next month baru ada diarrhea. Oh, yang ni depends. Alternating bowel diarrhea, alternating constipation ni bergantung lah. Dia tak ada specific duration. Depends on the patient. Okay, so but the patient will have constipation long time, then diarrhea. Okay, the constipation, diarrhea. The exact duration tu depends from patient to patient. Okay. Or is it alternative bowel habit tu mesti ada satu masa? Oh tak, dia once at a time. Satu tempo, maybe few weeks constipation. Lepas tu few days or few weeks diarrhea je. Lepas tu the typical presentation, patient will have spurious diarrhea. Maksudnya masa diarrhea tu najisnya menyembur-nyembur. The reason is because of the high pressure from the proximal bowel sebab apa dia dah, because is already impacted stool for very long time plus high pressure, and then when the feces from solid become liquefied, and then it will push down all the feces. Ni macam ni lah, macam pernah main ni kan, pistol nerve kan? Tak juga saya main tak pistol nerve? Nerve kan? Kan first kita load, lepas tu sekali release tu dia boom, menyembuhkan lah. Macam tu lah dia punya teori dia. Saya tahu sebab saya selalu main dengan anak saya. Dua orang kan, saya ada dua orang anak lelaki kan. So anak lelaki main tembak-tembak lah. Kalau anak perempuan main masak-masak kan. So main tembak-tembak dengan anak saya. Okay, next question. Ada lagi question ke dah tak ada dah? Okay, kalau tak ada question, saya pula tanya question. Okay, so kalau maths, okay, maths ada organ other than lung and the liver, can we still manage the patient curatively?
As of now, tak boleh lagi. No.
For now, tak boleh lagi. Teknologi tu still tak ada lagi. In the future kita tak tahu. Okay, especially ada part apa? Because metastasis can be anywhere. Whether metastasis to the bone, whether metastasis to the brain. Okay. For now, the technology is still not there. Still tak ada lagi. In the future kita tak tahu. Okay, itu kalau distant metastasis. Okay, tapi kalau locally advanced, kita panggil locally advanced. Example, patient have a rectal cancer, T4B. Go to the bladder. Okay, go to the bladder. Dia selalu yang pergi ni lah, dekat bladder ataupun dekat muscle Okay, we can manage curatively because we not consider that as a distant metastasis. We call it a locally advanced, which is T4B. So kalau kalau locally advanced to the bladder, so we have to do sama juga MDT juga, multidisciplinary team, and then we call lah our urology, Prof Nazli ke, Prof Islah ke, dan kita tanyalah, can you resect the bladder? Okay, so they will do either partial ataupun radical cystectomy. Okay, so because sometimes masa exam the student ni dia confused. Macam from kita cakap the tumor mass to the bladder. Oh, this one cure palliative. Tak, sebab we not consider that as metastasis. We consider that as a locally advanced. Okay, ada satu case masuk professional exam, patient dalam ward sekarang. Patient Ahmad Syaril. Okay, patient tu dia locally advanced rectal cancer. Dia locally advanced to the bladder. So patient come with the urinary tract infection. Masuk exam, urinary tract infection. The chief complaint, urinary tract infection, because patient have colorectal fistula. Patient have rectovesical, dia rectosigmoid, so dia ada colorectal fistula daripada colon go to the bladder. Kita akan buat surgery for the patient this Tuesday. Patient ni masuk professional exam. Dia punya chief complaint dia is patient have UTI symptom. Dia cakap ada dysuria, increased frequency kan. Lepas tu masa tu examiner, saya examiner kan. Okay, so tahulah surgery case lah. Urology pun still surgery case juga. Okay, tapi patient ni good historian. Dia akan cakap warna air kencing saya sama color dengan warna najis saya. Okay, lepas tu dia cakap air kencing saya ni berbuih-buih. Because of the colorectal fistula. Patient ada pneumochuria dengan ada fecoluria. Okay, then the student know lah, the patient have a locally advanced colon CA with bladder involvement. Oh, saya tak letak tadi dalam slide. Patient fecoluria ataupun pneumochuria. Okay. So ada lagi nak tanya soalan?
Mister, if diagnosis, if we suspect patient have colon cancer, can we for the differential can we first provisional right-sided colon cancer, differential left-sided, and then rectal CA.
Macam mana?
Macam kita divide pula dia punya macam ni provisional right-sided, differential left-sided colon cancer, rectal CA macam tu.
Oh, tapi right side dengan left side simptom dia lain. Okay, yang boleh, okay, my provisional diagnosis is rectal cancer. So my differential is left-sided colon cancer. Yang tu boleh lah dekat-dekat. Sebab yang right side, sebab simptom dia lain. Tapi patient sometimes tak clear cut Yelah, cakap apa, simptom dia ada diarrhea apa semua macam left side. Tapi bila palpate ada mass dekat right side. Okay. If you ask me, case to case basis lah, case to case basis. Kalau left side colon cancer, sekejap sorry. Apa Mr. Faisal lagi call pula. Yelah kalau consultant call takkan tak angkat kan. Ada kita ada op ni esok ni. Okay. Apa soalan dia tadi? Kalau apa right side colon cancer, boleh tak differential diagnosis left side colon cancer? Jawapan dia boleh. So case to case basis. So kalau ada history suggestive boleh je.
Okay, Mister. Thank you.
Okay. Lagi ada tak lagi soalan? Ada tak ada? Tak ada Okay, so kalau tak ada, okay, good luck. Hopefully this session benefit all of you lah. Okay, so good luck for your en bloc exam and your professional exam. Okay, and then I have a session sebenarnya dengan saya punya ni. Dengan saya punya surgical the year 5 in surgical